A patient showed up after 3 years of orthodontia. I think she had jaw surgery too. She did. Yeah, I don't want you to get the impression that I don't think orthodontia or perio or any of the specialties are not needed. So we as restorative dentists, we have to look at a case and understand what is needed to successfully complete a case. And what is successfully complete a case? For me personally, it means 15 to 20 years with minimal problems, functioning occlusion. When you do enough of this dentistry, you will see things do chip or things do break. It's a rarity, but it happens. And obviously satisfying what the patient had asked for. I just saw this patient, so I thought it was interesting to show you the case. You know, she was hysterically crying, tears of joy, which was great. Anyone going through multiple years of treatment, you become more and more apprehensive as the timeline to finish treatment becomes closer to the end, because you want to make sure you're making the right decisions. You know, you went through all those extra steps because you wanted the best result. And in this case, this patient came to me because they wanted her to go back into orthodontia after multiple years of having it, and she lost faith in the process. She was at the position she was at, she didn't like her teeth, and more importantly, she had literally no posterior occlusion. She had no bite on her back teeth, and she was pounding on the front teeth. And when you start to look at some of the signs and symptoms now, obviously black triangles occur, especially as you get older, but this black triangle is big. And sometimes when you see big ones like this, you have to start thinking like, is there some kind of occlusal trauma? Then you see the wear facets that are happening in her teeth. And if I show you a retracted of her teeth, you see something like this, that basically in her bite, all of the occlusion was on the upper and lower 6 teeth. Now she had, over the last 2 years of orthodontic therapy, been put into this bite. If she had continued on life and not had any back tooth support, these teeth would have continued to get traumatic occlusion and, you know, things like bone loss, gum loss, loosening of teeth, and eventually tooth loss and or root canals would have occurred. And so she had posterior crowns in the back of her mouth, and it was very easy to see this treatment plan and say, let's take off the old crowns, build up your bite in the back, and at the same time, we can restore the front of your mouth with new shapes and colors, close the black triangles, and make the teeth look better, right? So that's what she was really asking for. When we went in a case like this to prepare, you have to be thinking like, when you have these black triangles, you have to break contact, okay, in your preparation in order to recreate a new triangle between the teeth. What you're doing is you're raising the contact point apically to create the contact point of ceramic closer to the tissue so that you don't have these big black triangles. Now, the black triangles are not only aesthetically displeasing, but you're going to get food stuck in here and here and here and all these places, and same thing with the lower, which leads to a whole set of issues. The other thing we were able to do is take off these back teeth and restore her bite by recreating the occlusion in the back and then putting everything in together at the same time. Now, these cases can get tricky, so we always want to trial it in temporaries first and make sure that we get the right shapes. And now we're going to have to cheat, because if you really just close this black triangle, you're going to have a long contact point. So what we do in the aesthetic is we start to narrow the necks of these teeth so that they get more of a triangular versus rectangular shape, and then open the embrasures so that the contact point, although is going to be up here, it doesn't look as long as it would be. Now, the other thing that we're thinking about in a case like this is the incisal edge position is already long, right? So it's good here and it's long here. And that's also, canting from whether it be the orthodontia or however they placed her jaw. But we want to apically reposition these teeth. So we would take a little bit from the tissue here, here, and here, and we did that with a soft tissue laser. And then we would shorten from the incisal edge apically, because we're not only raising the contact points, but we're raising the incisal edge position. And as you do that, you can start to make a straight line parallel to the eyes and parallel to the frame of the face in the soft tissue profile and the incisal edge position. And when you do that in your preparation, and then you do it in your temporaries, you get to trial that your bite, your aesthetics, the color, and everything that you want to do right on this case turns out the way that you're planning on. Now, if you can see, we raise the tissue here, we shorten the incisal edge position here, so you have nice curves B. We gave really good back tooth support. Now this patient has a longer, narrower face, so you don't want to open her bite. You just want to restore her occlusion, because if you open your bite, you're going to make a lower third longer, which is going to be worse. We take all these reference points and measurements to be able to get an accurate depiction back from the lab. That's the top, and this is what the bottom looked like. And then we put it in. And here is a healed picture of what the ceramic looks like. Great posterior occlusion, nice closing of the black triangles. The tissue is still filling in. We put this in about a month and a half ago. Great color blend, great triangular shapes. The contact points don't look too long. And here is what a final smile looks like. And now, again, now you can see it's off of her lower lip, which is great. It actually raises her smile in her profile, so you can see, which you can't see, but facially, she does not look as long and narrow as she once did. But more importantly, the patient was crying in the chair and said, I was so nervous coming in because I didn't know what shapes you were going to choose. And it's an interesting thing to think about the patient's apprehensions coming into somebody permanently changing the way that they look. Now, to us, the dentists, it's kind of, we go through it every day, so we sort of dehumanize it, but more importantly, I think sometimes we have to step back and put ourselves really in a person's shoes of saying, like, I know there's nothing that I can really do to control this process, so I have to trust you. And with all of the failures that you can see and all the horror stories, it becomes scary. And I told her, though, the interesting thing, and I still don't know how to go about this, but when I see a person within a few seconds of seeing them interact with me, I have already envisioned what their teeth should look like and what I want to do. And the truth is, it's nearly impossible for me to take all of that information and be able to tell someone so that they feel comfortable, right? Because what tools do I really have to show real three-dimensional, to the 10th or 100th of a millimeter, a smile? Like when you say, I want to make this bigger, their bigger interpreted to them is like huge, or I want to make this smaller and are my lips going to fall, or I want to make this whiter, well, not too white, or there's so many descriptive words we're using to try and generalize or simplify what it is that we're trying to explain, that the only way to really get this done is to go through the process. And it is horrifying. And I understand that. For me, when I'm working on patients, it is second nature to see exactly what I want or at least have a very good idea of what I want to try and do. And then, you know, I don't really see it until I get into the patient's mouth and I'm working, because I'm doing everything by hand. So I have to make occlusion work. I have to make the aesthetic work. And sometimes those things don't go hand in hand, and you have to, you know, either compromise or make it happen. But trying to explain that preoperatively is nearly impossible. So, but this was a good case that worked out, and you know, that's what we're here for.